Yeah,
Probably.
they're waiting. Okay, for those who don't know me, I'm Marcy Lidman, and I will be moderating this evening's program. Welcome to the next in a series that has run much longer than anyone anticipated of COVID town meetings. We are very fortunate in our community to have many knowledgeable people about many different things. Tonight, we're going to have people who are knowledgeable about COVID speak with us and answer questions. Some of those questions have already been submitted, and we will answer those first. And then if we have time, we will open it up to live questions and answers. So here's what the program will look like. I also would appreciate if everyone would mute except for the speakers. I'm going to introduce you to the panelists, and then each of them will speak for a little bit about their area of expertise, and then we'll get to the questions. So our panelists this evening, and I'm not going to list their pedigrees because I would get them wrong, and they were all very long and very impressive. So I'll just say a little bit about them, and they can introduce themselves as they speak. So Mark Bobrow, in addition to being our esteemed president, is a chemist. Is that your training, Mark?
I'm a biochemist.
Biochemist, and works with vaccines.
No, I don't. I work in the diagnostics and testing industry.
Okay.
And I'm part of.
This is why I shouldn't say anything.
Okay. And
Okay.
I'm also part of the RADx program, which is Rapid Acceleration of Diagnostics for COVID.
Okay, thank you. Dr. Wendy Heiger-Bernays is a professor at Boston University in the School of Public Health. So Mark is going to be talking about the current situation in Massachusetts along with our Temple Emunah policies. Wendy, who in addition to being a professor at the Boston University School of Public Health, is also chair of the Lexington Board of Health. And Wendy is going to be speaking about the current situation in the schools. Dr. David Geller is a pediatrician at Bedford Pediatrics, and he and Dr. Leah Meisinger, who is a surgeon, are going to be talking to us about kids and COVID and the vaccine. And Leah, I think you've been doing something else since being a surgeon, so you can share more information when you speak. Okay, so I am going to turn it over to Mark. And Mark, you should be able to share your screen.
Okay, let me see if I can do that.
And if you have any questions for the speakers, if you could put them into the chat, and then I will respond to those questions.
Let me get this in. There we go. Can everyone see that?
Yeah.
Okay. So what I'm going to do is I'm actually going to review some of the current case numbers and what's happening in the United States, Massachusetts, and Lexington. And then I'm going to switch to a little bit of science. So I apologize for the non-scientist. I tried to make the presentation relatively easy to understand because there's very late breaking news as of a couple of days ago in terms of what we understand about, especially about COVID infections, especially about the Omicron variant. Then I'll go through some testing slides and I'm going to answer some of the questions that people had with slides in terms of how accurate tests are and why we can't find them. And then I'll just wrap up. I don't want to talk about policy right now, but we can bring that up after. Okay, so cases and trends. And so this is actually many countries. And if you can see, actually, let me just move this so I can see it. If you can see this, how we're doing compared to the rest of the world. This is the United States. We're not doing that well. We have very large numbers and they're going up at an alarming rate. Okay, so let me get a little bit closer. This is only United States. This is actually daily numbers through Friday. And the case numbers are actually doubling about every week. And so we won't find out until at least Tuesday what Monday's numbers will be. And typically weekends are low because there's not a lot of testing going on. We see something very similar in Massachusetts. It's a little bit harder to see this individual numbers, but they're up to here as of last week in terms of every single day. And this is the 7-day moving average. But again, they're approximately doubling every other week. We're seeing the same thing in Lexington. This is through Friday numbers. Okay. So as you can see, we've got a huge spike happening. In terms of hospitals, we've already exceeded some of the highest peaks we've seen, and I think we're hearing that the hospitals are getting overwhelmed with patients. Okay, there are reports that the Omicron variant is not as severe, and I actually have data to indicate that it's not from a mechanistic perspective, but the number of cases is overwhelming our hospitals, as is, especially because of the unvaccinated, they're the ones that are for the most part ending up. And here's another slide which breaks it down by age, and there's age groups, and really the most striking numbers here is the 0 to 17 is this line down here. It's already spiking higher than we've ever seen before. And then the next age group as well, the 18 to 29 group, is this light blue line, which is already up to here. If I can draw, oops, I went ahead, let me go back up. If I can draw a line across, you can see it's up to here already, so it's probably double of what it was back when we had Delta. So clearly, where we're seeing the biggest differences right now are in the younger age groups, and I believe that's what the hospitals are reporting. Okay, so let me talk a little bit about the latest research, because it's really, really interesting. And for the most part, I'm going to focus on 2 studies that came out of the UK, one in London and one out of Glasgow, Scotland last week. Okay, so what are we learning? And I just need to move this so I can see it. So, you know, we are hearing reports of there being increased transmission and reduced severity, but can we show that from a mechanistic perspective?
There's something down here that makes you.
Hang on, let me just try to. Okay, here we go. I just need to keep moving the pictures of everyone, otherwise I can't see my own slide. So I'm going to go over the way SARS-CoV-2 infects our cells. So I'm going to have to deal with a little bit of science there. I'm going to show that or at least the data indicates that the Omicron variant mode of infection is very different from the other COVID variants. And then once infected, it spreads differently within the host. It infects different cell types than the other variants. And it's also evading our immune systems. So first, a little bit of science. There are 2 modes of entry for coronaviruses, and I'm going to start with one here. There is an ACE2 receptor on our cells, and these cells exist in our lungs, in our nasal epithelium, our throats, and many other tissues in our stomachs. And the SARS-CoV-2 virus and other viruses also sort of have a key on them that unlocks and binds to this, and then can open up a door, let's say, for entry. But what it also needs to happen is there is an enzyme on our cell surfaces that cleaves a protein here that enables this to happen. So it's a 2-component mechanism. It's binding, and then it's cutting, and then it enters. And actually it fuses to the cell membranes and releases its nucleic acid contents into the cell so the virus can replicate. The other mode that some of these viruses enter is only by binding to this ACE2 receptor, and then it's engulfed by the membrane. It's called endosomal, like this, and then this opens up and it gets released. Okay, so I just want to focus on those 2 mechanisms, and I'll show you how we know why they are and what the difference is in in the different variants. Okay, so how do we know that this actually occurs? Because in cell culture, these pathways can be blocked. So if you add a compound or drug, in fact, that blocks this pathway, you can prevent the virus from infecting cells. If you block this pathway, you can, prevent some of the viruses from infecting cells as well. And that's actually the way it's been done. So what we found is that variants such as Alpha and Delta actually have an enhanced binding to this ACE2 receptor. They also have enhanced cleavage here, and they are very effective in entering the cell through this mechanism. As it turns out, the Omicron variant does not. The Omicron variant actually binds very tightly to this receptor and does not respond to inhibiting the cutting mechanism. And so it actually enters our cells by a very, very different mechanism than Delta does. And what that means is it's actually broader because there are more cells that have this alone than have this combination. In fact, in our nasal epithelia, there's about a 6-to-1 ratio. There's 6 cells that have this compared to this. Okay, second thing is when the viruses enter by this mechanism, they tend to form something called syncytia, which are fusion of cell membranes. And once infected, and I have a great picture to show you what this looks like. Once infected, an infected cell will now fuse to another cell, and the virus can pass from cell to cell without having additional viruses infect another cell. So there's a very strong means of infectivity from cell to cell without having additional virus added. Okay, and Omicron.
Bob, I don't know how to hear the meeting. They're on already. It started early.
Can we get folks to mute, please?
Please mute.
I got the video. Oh,
Okay,
sorry.
and so, I'll wait.
Perhaps the host can mute.
I am looking for the person who is unmuting. Thank you, Donnie.
Got a slide up and I have no idea. Okay, I have our pictures here.
Harriet, can you please
Is
mute
that
yourself?
something to
Thank you.
slide? You're looking.
Harriet, can you mute, please? Thank you.
She's muted. Okay. So let me show you what this looks like. And this is just published online last week. It's really, really well done. So this is fluorescent microscopy, something I've done tons of. And each column is a different. This is native. This is the original strain. This is Delta. This is the Omicron. And it's fluorescing green when we have cell fusion and syncytia formation. So what you can see is Wuhan does a little bit, Delta does a lot, and Omicron does very, very little. In terms of infectivity, the red is actually staining the nucleocapsid protein of the virus. And so you can see that there is red staining everywhere, but the big difference is you can actually see the red staining within the cells and between the cells, whereas Omicron almost looks like punctate, looks like little dots. So you're not seeing a lot of cell-to-cell transmission, and that's really important because it's harder to for the virus to replicate unless it's forming syncytia. And syncytia formation has been found in the lungs of many very, very severe infections. And then this is just staining for the nuclei, and this is put all together. The other really interesting finding is that, again, this is in cell culture using either nasal epithelial cells or lung cells, where they incubated the cells with a 50-50 mix of Delta and Omicron. And what they found here for the nasal epithelial cells is that an Omicron is in this sort of purple color and Delta is in green, is that over time, the Omicron variant actually outdid Delta in terms of infecting the nasal epithelial cells. But even though Omicron started out stronger, over time, Delta took over for the lung cells. So the implication here is that the Omicron variant really prefers to infect and has an advantage infecting our nasal epithelia, and Delta has an advantage infecting our lungs. In terms of immune evasion, and again, this is out of Europe, so they basically were dealing with the Pfizer BioNTech vaccine, and then also this is the AstraZeneca Oxford adenovirus vaccine. But what you can see is that the Omicron variant, and this is antibody titer by inhibition, not by just binding. You can see that there is still protection, but it's far lower against the Omicron variant. It is improved when boosted, and actually it's better over here. There is a bigger advantage here for the original dose with the AstraZeneca, and then these were boosted with the Moderna mRNA vaccine. So clearly is lower levels of protection against Omicron, but boosting really helps. And I think we've heard this as well from other sources. So this is really showing us from a mechanistic perspective what we're hearing, that the Omicron infection seems to be more in our upper respiratory area, our throat, our nasal passages, less likely to infect the lungs severely, whereas Delta is the other way around. And so that would lead to a little bit less severity, at least in the vaccinated, and would explain some of the things that we're seeing. Okay, so quick summary is that. So
And they're up. Out of the gate, it's coronavirus.
Sorry.
you found it.
Yeah,
Go,
that's not-
Marcy.
You found it. Okay. So Omicron variant infects nasal cells more efficiently than Delta. And again, I counted cells that were listed in the table, and there were about 6 times more cells for Omicron to infect versus Delta within the nasal epithelium. Now, there's also more data, and I didn't want to get into that, but the endosomal route of infection, Omicron is partly refractory to cell defense mechanisms. So cells have their own defense mechanisms to protect themselves from being infected that mode, and Omicron is partly refractory, means it has its own way of evading the cell's sort of protective mechanisms. Delta likes to infect lung cells better than Omicron, and then Omicron transfers without syncytial formation, whereas Delta does, and vaccines have reduced efficacy against the Omicron variant. And all this starts to tell us, from a mechanistic point of view, what we actually are seeing in terms of infections. And also, because the Omicron virus is concentrating in our nasal epithelium, we're probably putting out more virus, because it's not coming up from the lungs, it's coming right from our throats, our saliva, and our noses. Okay, let me give you a quick testing update. So there was a question about, why can't we find tests? So let me address that. So first of all, companies produce these tests, not our government. And these are all for-profit companies. And they will not invest in the infrastructure, and that's very expensive capital equipment and facilities, and the people to scale up testing unless there's continued demand. And companies that and so the equipment that they use are also manufactured by other companies, and those companies are also not going to scale up unless there's continued demand. And not only that the equipment is extremely complex, and it takes months from the time you were to order it till the time you actually can get it delivered. So there's huge lag. Also, demand went down in the middle of 2021, and these manufacturers scaled down and let people go. Anecdotally, I know someone that visited one of these manufacturers in November, and there was a completely vacant manufacturing facility, vacant of people. It was fully loaded with equipment that could be used to be making these kits. It was not running. It was just sitting there idle. And the reason is because there was a lack of demand. And so one of the reasons why we don't have that many kits is because demand went down in 2021, manufacturers let people go and reduced, and now it takes time to scale up. It takes a lot of months. The second thing is we don't have that many companies making kits because the FDA set a pretty high bar. Now, emergency use authorization is a lower bar than a typical FDA approval, but it's still a higher bar than what we've seen in Europe and other countries. It doesn't take much to commercialize one of these tests outside the United States. And I would say thank goodness, because a lot of the tests that are commercialized outside the US are really bad. Their performance is atrocious, and yet people can buy them and use them. Okay. Now, capacity is expected to increase. I pulled this table off a weekly newsletter from Mara Aspinall. And if you can see January, and this is in millions of tests per month. So they're projecting 260 million tests to be produced in January. This is at home tests, and it should double in about 2 months. And there are manufacturers. Abbott is building a huge facility. Illumina is building a very, very large facility now. So they are ramping up. They should be doing it. A typical manufacturing run at full scale is probably about 200,000 tests per day per group making it. But they don't start that way. If you just had a test approved by the FDA, you're probably making 3,000 tests a day. And it takes time to scale up. And these tests are very complicated. They're not easy to develop. They're not easy to build. And a lot of quality control has to go into them. And there could be supply chain issues with the parts as well. What I can tell you is that the NIH is actively funding and prioritizing clinical trials for companies that can rapidly scale up. And if you're curious, you can Google ITAP COVID-19. I know of some of these programs, but in truth, the only way to permanently alleviate this problem is for the government to stockpile completed tests and test parts, just as they do for the defense industry. And if the test has a 12-month shelf life, they need to continuously have them produced and shelved and then tossed when they expire, if not used. That's the only way we're going to have a continued supply of tests like this going forward and get us ready for the continued pandemic and perhaps the next one. And some of these recommendations have been made to the White House. I mean, I was part of a task force that was involved in recommending how to alleviate the supply chain for the parts that go into these tests. And that was the recommendation we made, that the government actually has to buy the components and stockpile it. Okay, let me talk about accuracy. So home tests for anything, what we call lateral flow tests, the ones that go up the strip and you see a couple of lines, those are the least sensitive of all the tests used in diagnostics by quite a bit. And the reason why they're the least sensitive is because that they sacrifice sensitivity for a rapid result, a low cost, and ease of use. Now, if you remember, most tests that are made in diagnostics are made for professional laboratory people to use them, people who are very, very skilled. And it takes quite a bit of engineering to make them foolproof for the average layperson to use them. Okay, and so in doing so, they can't have the performance of some of the other tests. So, you know, from an analytical perspective, I'm not talking about clinical sensitivity saying that this test is 95% sensitive or 80% sensitive, but if you were to take some SARS-CoV-2 virus and put it in one of these tests and then make less and less and less of it, you could actually measure the amount, you would find that these home tests are about 1,000 to 10,000 fold less sensitive than the gold standard RT-PCR. Meaning RT-PCR can detect 1,000 to 10,000 fold less virus in that nasal swab.
Mark, there were a few questions. Sorry, I'm a little bit behind. One person wanted to know, since Delta and Omicron have different mechanisms of infection, can somebody be infected by both at the same time? Probably,
and I would suspect someone who's going to be infected with both would be someone who's unvaccinated. The very early reports just after Thanksgiving coming out of University of Illinois and University of Washington was they were observing Omicron in vaccinated people and Delta in unvaccinated. But it's not 100%, but that seemed to be the bias. But there's absolutely no reason for someone to be co-infected. Especially, I mean, I think that most of the vaccinated people are protected against Delta for the most part, probably less protected against Omicron. You can be co-infected. And unfortunately, that could potentially lead to the emergence of new variants, and that could be pretty frightening. Something that has the efficiency of Omicron and perhaps the lethality of Delta could come out. And so that's another reason for people to get vaccinated and boosted. Was there,
And okay.
was there another one or?
Yeah, the other question was, are current tests going to be valid for subsequent variants?
So right now they're looking at the Omicron variant, and it seems to be that they are slightly less sensitive against the Omicron variant, but the full set of data is still being generated right now. About new variants, we just don't know. So let me just add that almost every one of these tests, the antigen tests, measure what's called the nucleocapsid protein, and that is the protein inside the virus, the viral membranes. Most of the mutations we are seeing are outside, where the virus attaches to the cell. That's where we're seeing the mutations in Omicron and Delta and the other variants. There are mutations in the nucleocapsid, but they typically are fewer. And so most of the tests will still pick them up. Now, there could be another variant that they won't pick up. There's no way to know.
All right, just in the interest of time, can you summarize any further information?
I'm almost done. Let me just finish up. So in terms of accuracy, so I have a couple of slides. So in terms of accuracy, people are concerned about sensitivity. These tests are not as sensitive. False positive rates are typically 1 to 3%. That's expected. That means 1 to 3 out of 100. And there have been some isolated reports of large numbers of false positives, and those have been traced to specific lots of kits, both from Abbott and Emunah. And so let me just go through this one slide because I think it's important for people to understand. What's really important is not the sensitivity and specificity, but what's called positive predictive value and negative predictive value. And that means is if I get a positive result, can I trust it? And if I get a negative result, and can I trust it? So it turns out that if you get a positive result, you got a pretty good chance you have COVID. Okay, if you have a negative result, on the other hand, if you're symptomatic, there's a likelihood that you don't have COVID, flu, or a cold. If you're not symptomatic, or if you're what now they're calling now pre-symptomatic, and you get a negative test, it's only presumptive negative. You could easily be positive. So if you're using these tests to make sure you don't have COVID before you gather in a group, that's not a good way to go. Because if you're not symptomatic, you really can't trust the negative result. And I think that's coming out. And that work is being studied right now. And I've already heard from the principal investigator, and she said that Abbott Binax, Quidel, QuickView, iHealth, and several others are just totally failing in picking up these pre-symptomatic but infectious people. Okay, so I did want to just talk about one other kind of test. There are at-home molecular tests. They are very expensive compared to the lateral flow antigen tests. And I can post these links if you want. There's one from Lucira. It's right now at $75 online. I think it's available. It's single-use disposable. These are better than the antigen tests. Q Health is one that's actually used by Google to screen its employees. There's a little instrument that costs $249. It's reusable, and then you can buy packs and bulk packs of tests. And then there's one from Detect as well, that you need a reusable hub, and then it's $50 per test. I think that's out of stock right now. And let me just add one more thing. There's a rumor mill going around based on a couple of publications last week that said that you should be swabbing your throat and using saliva instead of taking a nasal sample. The data it may be true, eventually we may find out. The data is not convincing. And worse is that the presence of saliva could mess up some of these tests. We just don't know until the manufacturers verify that they can be used with saliva, and then they validate that they work in that mode. Okay.
So Mark,
so-
there's a question. Does this mean that there is no reliable way to rule out whether an asymptomatic individual is possibly infectious using a home antigen test, including
absolutely-
nasal fluids?
That's correct.
True. Okay. And the other question is, if you look into your magic crystal ball, do you anticipate that the variants to come will be more or less dangerous? And like, what do you see as variants coming down the road? I mean, is this the way that we're going to be living now, that variants will continue to come?
Yeah, I think there will be more variants. My gut feel is that they're going to end up being like flu. They'll probably be infectious, but less severe. And then we'll need boosters every year. And there'll be variant specific boosters, just like flu. I know I had a quadrivalent or tetravalent, meaning there were 4 variants of influenza in the vaccine. They'll do the same thing for COVID. And you can also get a combined COVID and flu vaccine, probably be available for the fall of 2022. Okay.
Well, thank you for that sobering news. Okay.
I'm going to stop sharing.
Okay, so Wendy, do you have slides or not?
Well, I think in the interest of time, I won't show them because the semester has not started. So I'm still sort of on teaching break. I think instead what I will do is go through some of the questions that were asked. And I will start with, there were some questions or I was introduced as being here to talk about what's happening in the schools. So I'll start with the schools and then I'll go to some of the questions. So in the schools, we know that the children are back. I will tell you what happened in Lexington. This happened across the state where the governor and the Department of Elementary and Secondary Education was able to get hold of some of the tests that Mark referred to and distributed them to teachers. Last week, at the end of the New Year's weekend, Lexington was out of school on Monday in order to allow the teachers and staff to be tested. The tests came back and we know that of the tests, of those tests that were given, there were some 250 or so positive results. Those are teachers and staff. We were looking at about a 5% positivity rate in that population. That sort of wreaked havoc because then you have faculty and staff who are out. The children came back on Tuesday and there was no routine testing administered on Tuesday for the children. The state will go back to what they call the test and stay program in order to hopefully catch the children who are positive. We know though that the rates have increased, the numbers of children who did test positive, and David Geller can speak more to this about what's going on in his office. The reality is that the numbers are increasing in Lexington, in the schools, and across the state. Some of the challenges are that, as others have pointed out, the inability to get tested. And if we think about the vaccination rates that we do have in the Lexington Public Schools, like we know that for some of the grades, in particular, 8th grade seems to be nailing it. They are right on. And there was a question in the list of questions about how we define fully vaccinated. And the question was, will the CDC be updating the definition of fully vaccinated to include a booster? First of all, the CDC is keeping fully vaccinated as they're keeping the fully vaccinated as, excuse me, the 2 shots for Moderna and Pfizer, 1 for the J&J, but adding up to date for boosters. And this is consistent with the CDC's description of other vaccinations and consistent with the World Health Organization for international vaccination guidelines. So as we know, the older children can now be boosted. And so we're beginning to see larger numbers of children being boosted in the Lexington Public Schools. And this is happening pretty much the same in Belmont and in Arlington. I can't speak to the other surrounding communities. Now, in terms of how the rates of, so that's rates of COVID, Mark showed a graph of what's happening in Lexington. We have seen last week alone, actually it was a 5-day, was 350 cases, which is the largest number of cases that we've seen. If we take into account the fact that we can't get the testing, and perhaps the testing, the home testing is not picking up enough of the people, we're actually underrepresenting the numbers of cases that are actually out there, which poses challenges to how we get, how we interact with one another. There is another metric that's used, and nobody asked about this, which is the wastewater testing that is done in our wastewater treatment. I won't show you the graph, but I'll tell you it's off the charts. And what happens is when we poop, so I work in environmental health, and we do the really sexy things like poop and bad air and all that stuff. And I'll talk about air in a second. When you are infected, and actually before you even know that you're infected, you are actually shedding virus. And that virus can actually be detected in wastewater. So when you flush the toilet and that poop, our poop in the sewer system, we think it just goes away. It actually goes to Deer Island, which Marcy knows dear to heart, which is the Massachusetts Water Resources Authority monitors that. And what we know is that the levels of virus are off the charts. And those samples can now be sequenced. That means we can actually go in and see which variant is there. And we know that the Omicron or however we want to say it is really off the chart. So we know that the levels are increasing. So we've got multiple metrics to be looking at. And I wanted to mention a couple of other things because of the questions that were asked. And that is questions about, there was a question about OSHA. The OSHA requirement for vaccination or testing only applies to companies with over 100 employees. And why has the government not made this a requirement for smaller businesses too? This is an economic decision. OSHA, the Occupational Safety and Health Administration, actually has different rules for different sized operations. And this is consistent with the way that our federal government works. In fact, the federal government has different rules based on numbers of people for a number of different industries and a number of requirements. We know this with the ACA provision for healthcare, and I'm going to bring in drinking water here. Even the EPA has different rules for small versus large drinking water supplies. So the fact that the OSHA requirement is being applied to larger companies is really an economic and political decision. There was a question about, there was a statement that epidemiology should be part of health education in Lexington and other towns. I don't think that's a question. I think that basic science reading and math would be actually, and critical thinking would be useful. Epidemiology maybe. There was a question about what KN95 masks should I try for my kiddos ages 9 to 11? And can you give your opinion on the rapid change in standards from the CDC? How about we step back a little bit? And I don't politicize the CDC. Let's go back to the mask question. So this is something that we've been working on both in my work life and certainly in Lexington. And that is this evolution of the issue of masking. Masking works. First and foremost, and we learned this early on, and what we've learned since the start of this pandemic is absolutely enormous amount, right? Remember when we met, I think it was about a year and a half ago, and we were washing down our cans and our mail, and we were disinfecting absolutely everything? Well, we have come a great distance, people, right? We are finally listening to the science, and we are finally listening to the fact that these viruses are spread in air, right? So it's shared air, which is the pathway to inhalation of viral particles. This nonsense, if you will, about 3 feet and 6 feet is simply that, right? We actually have to think about how these particles disperse in the air. And what we're really, again, thinking about is shared air and how we can decrease inhaling and exhaling the air that you and I are sharing. So one way to do that is to dilute the air, open the windows, increase the ventilation. Another way is to filter that air with a HEPA filter, for example. And the other way that we have is through the use of masks. First and foremost, masks have to fit. They cannot be hanging off your nose. They cannot be chin warmers. They cannot be neck warmers. There's nothing cool about having a mask that is dipped below the nose. So first and foremost, those masks must cover nose and mouth. And you cannot have space on the top, on the side, where you can stick your fingers, or you can actually, if you breathe out heavily, you can actually feel the air coming out. Okay, so first and foremost, masks must fit. Second, what we know now is that mask efficiency is increased by using mask, or mask efficiency increase with the type of mask that is used. We know that the highly effective masks, I'm gonna share I do have a picture of this, and I think it's important. I'm going to jump to mask efficiencies and recommendations. And first and foremost, the fit over the mouth and nose. Second, what we know, and Mark told you about why this virus, this Omicron, is maybe so transmissible, right, is that you have higher concentrations in the nose. And also we have learned that the cloth masks do not provide the kind of protection that's really needed for this highly transmissible Omicron variant. We do know that there are 2 other types of masks. There's the surgical mask, which is actually less efficient at the smaller particle filtration, which means that first, you can actually get more you can get more of the virus actually through the filter in both directions. And the masks that protect most efficiently are those that are called the N95s, which are US masks. They are certified by NIOSH, which is the National Occupational, and it's the research arm of Osha, and they do the testing for these masks. So NIOSH is testing the N95, which are certified in the US. The KN95 is certified by the equivalent of the Korean officials, the Chinese officials, the KF94 by the South Korean officials, and the FFP2 by the Europeans. So all of these masks are much more efficient in preventing transfer of the virus from you outwards and from the air into what you are breathing. This is simply a picture of how this works. I will point out, I'm going to stop sharing, but I will point out that fit of these is absolutely imperative and comfort is also important. But the point is that you need to be able to wear a mask for a longer period of time. It needs to be comfortable, but it needs to fit. And if you can, and it's possible, and you can obtain the KN95s or these other efficient masks, that's the best thing to do. Highly recommended not to purchase over Amazon unless you are purchasing a specific brand that you know what you're purchasing. There are a number of fraudulent, I'll say fraudulent things on Amazon, and you cannot be certain that all of those masks are meeting the proper criteria. I think that's all that I wanted to say about the masks. There was a question about children's masks. There are a couple of companies that are available. One is the Bluna Face Fit KF94 for younger children, and there are a couple of others. I can make those available. The important thing about these masks is that you can actually use them more than once, and you should use them more than once. Remember, the testing for them is actually for 40 hours worth of time. You can hang them up, dry them out, do not disinfect them, and do not wash them because then they will degrade, but you can reuse them.
Wendy, I put that, what you put in the spreadsheet, I put in the chat.
Okay, great,
So
thank you.
the information about the masks for kids is in the chat.
Thank you, and thank you, Stuart, for the project N95. Yeah, so we've come a long way. We're now using masks, recognizing that we can actually protect ourselves and the people around us. But again, I'm going to reemphasize vaccination, number one, masks. Number two, stay home if you're ill, always. I think I'll turn it over to maybe Leah or David, since I'm looking at the time. And so one
Leah,
of
do
you
you want to go? Leah.
Sure. I don't have particular prepared talks. I don't know if David had anything in particular to say. I can address some of the questions that we had.
Sure.
If people would like that. Several of them I think were pretty well covered. I think one thing we have not covered as much is a little bit tricky, but it's this sense of risk and risk tolerance in communities. So there were quite a few questions that got at slightly different angles of it. But the biggest take-home message, I think, to keep in mind is there is no such thing as a no risk situation other than being completely, totally isolated. Just like wearing a mask, there's no perfect mask, there's no perfect test. So it's all, in everything we do, we're always taking risks. And it's just a question of what people's risk tolerance and risk managements are. And I think there's a lot of media that is reporting that Omicron is milder, and that's making people think differently about it, but something we don't really have thorough data on that to act on yet. So that it's just too early to have. And that's important to remember. And I think another thing important to remember is that we also have to think as a community and as a larger society group. So if the numbers, even if it is milder, if the numbers are so high that all of our health systems and other systems are overwhelmed, you can still have worse outcomes. So, because I think some of the questions we're getting at, do we not worry about it anymore? And the answer is we can't say that right now. we just have to keep trying to all assess what risks we're comfortable with, both individually on an individual level when you make your own choices, and if you're part of a community, that community trying to make its, risks based on its communal needs and values. That said, I think the COVID committee wants to make sure people know that at the Temple, we're trying to be very inclusive and keep in mind a wide range of people's needs when we try and help make decisions for everybody. Mark, is that, you agree with that?
Yep. And inclusive means, we need to be cognizant of having members who are immune compromised, who are, have other health issues that if they did get infected, it could be pretty serious.
Okay. So we also had a few more nitty gritty questions about the when to test and those kinds of things. If you know that you have been possibly exposed or around somebody who is positive, generally testing sort of 2 to 4 or 3 to 5 days afterwards. It's the sort of incubation time for Omicron is roughly 3 days. Obviously, it can vary in different individuals. So that's just a guide. And clearly, obviously, if you have the onset of any symptoms, that would be a time to test as well. I'm trying to.
Leah, when you say test, are you saying based on what Mark said that you should get a PCR test?
No, so the home tests, the over-the-counter home tests, if it's positive, it's extremely likely you don't need to then confirm by a PCR test. If it is negative and you remain symptom-free, that's considered you should still mask, but you don't have to self-isolate. If you have symptoms and you test negative on a home test, you should definitely get a PCR test to confirm.
Okay, thank you.
Do you have any questions, Marcy, or do we see, since the time is running quite long, David, do you want to talk for a little bit and then we can field newer questions?
Yeah, I can be brief. I have to say that thank you, Mark, for all the information you gave. It reminds me of why I'm in primary care versus clinical science, and some of the lectures I might have slept through. Information was all great, but you gotta have to be able to integrate it. But Wendy woke me up with a poop. Being a pediatrician, that wakes me right up. So I appreciate that. So one of the questions that just up my alley was kids and what we're seeing with the kids. And my office, and going back to what Leah says, is, what is your risk tolerance? Like, my office is testing a lot of patients, parents actually, who are asymptomatic. We offer that. We've been doing this since 2020. We probably run over 5,000 tests. Initially, they were just send out PCRs when they weren't available, when rapid testing wasn't available. But we've been doing a lot of molecular rapid tests, as Mark talked about, the Abbott molecular nucleic acid amplification test, which is a pretty high level test above the antigen, a little bit below the PCR. And we've had, in the past few months, quite the bump, I'd say. We've had lots of people tested, lots of kids and parents positive. I would say that anybody who's been vaccinated as an adult, a parent, if not a patient, 5 and up, has had mild illness, which has been very nice. We've had no hospitalizations, so nothing too significant. Everybody has improved quickly, and not to globalize this, but at least the kids I've seen as low as 2 months, not huge numbers, but 2 months and up, who are unvaccinated under 5, have also done very well. Mild illnesses. We had one infant hospitalized just for the fever, not specifically for the illness, at 6 weeks of age. Vaccines do work. I would say it's almost, to me, and I might be going a little rogue saying this, it's almost the exact, it's kind of, we've come full circle almost. To me, back in 2020, if you had symptoms of COVID infection, we had no testing. We assumed you were positive, stay home, don't get tested, nothing to be done. Now we're basically seeing the same thing. If you're exposed to someone and you have symptoms, you probably have COVID. And testing is helpful. Unfortunately, as Dr. Heiger-Bernays could speak to, we're not really doing a lot of contact tracing now. So she said we are probably very much underreporting what's out there, because we're seeing a lot, but now kids aren't even coming in because they have symptoms, they're positive on a home test. People are accepting that right now, home antigen test, because they're symptomatic, as Leah mentioned. And so we're probably not even seeing, there's probably a lot more patients out there. So the answer would be we're seeing a lot more COVID. Thankfully, the patients I've seen have been mild, but as Mark has mentioned, there's been a huge increase in hospitalizations of younger kids. A lot of these kids, have COVID. Maybe they're not all there because of the COVID, possibly, but they do have COVID. And the last thing I would just comment on is someone had asked in the pre-questions about long COVID in kids. What are we seeing for long COVID in kids? And to me, that's tough to answer, because young kids can't really express some of their symptoms, which could be associated with long COVID. It's almost like wondering if your infant is having a nightmare. You really can't tell. So it's really, the data is out there. Again, they've been mild illnesses, but I respect this disease highly, and I don't want to risk children, parents, anybody getting this illness and having some sequela that could last a while.
So Dave, there's a couple of questions. One is for high-risk people who are vaccinated, boosted, is it safe right now to go to grocery stores, inside restaurants, etc.?
I'll pass it off to Mark. I mean, again, as Leah mentioned, I would say it's really good risk tolerance. And as others have mentioned, I mean, this is spread respiratorily, and Omicron, is very contagious. So I think with a vaccine, personally, my tolerance would be yes. At my age and my health status and my vaccination status, and me wearing a mask outside in public in a grocery store that wasn't too crowded, I would feel very comfortable being there. I can be honest with you. I was at a Patriots game about a month ago on a Sunday, right after Thanksgiving. This was just all ramping up, and I was unmasked outside in a large group of people, and I felt comfortable there at the time. Looking back, maybe not so, but I think masked, vaccinated in a large environment, I'd feel comfortable there. And it's all your risk tolerance and your health status.
And I would say that I would agree with that. Going shopping, if you're only in and out in a little bit of time, if you're vaccinated, boosted, and masked, it's fine. But someone did leave a question earlier about VSO concert. Cindy and I actually had tickets for January 16th, Sunday matinee. We're not going because the length of time, you're sitting there for hour and a half, 2 hours, the number of people, the density, I think it's risky. But again, it's personal. It's a personal risk decision.
I think I'll just add on, because I think one of the questions also asked about restaurants, and I think it's a very different thing if you're thinking of an environment with your mask off versus mask on. And again, it's still personal tolerance, but I think mask off indoors is a very different thing with Omicron at the moment than it was with Delta earlier in the fall, and what people had started to get used to. So for me, I'm going to grocery stores, but I would not be eating in a restaurant with my mask off at the moment. But again,
I would agree.
Everybody's level.
Yeah, I would absolutely agree. The taking the mask off and sitting and with other people is at this point for me too high a risk to take, even though vaccinated and everything. Just too high. We look at the numbers and we understand the testing is not picking up everybody, and it's not just a cold that you're going to get. So I think that's the other important thing. And I think if you look at some communities, some have mask mandates in the towns and others don't. The governor in this state has left it to the locals to decide what they will do. Although if you look at his words, he says that he is providing guidance that suggests that masks might be appropriate. So local communities, with the exception, I think, of Burlington and Woburn, do have mask mandates. Lexington will be revisiting it on Tuesday. I believe that we probably have the votes to retain the mask. I think the data are very clear. What we will be looking at and what we've looked at in the past are what are the local, the county, and the CDC numbers look like. What we would be looking for is consecutive weeks, 3 or 4 consecutive weeks of downward trend. And we would also be, and that's in terms of numbers of cases. And there are a couple of other considerations as well. One thing we did not mention, we did mention it with regard to clinical care and overwhelming clinical care and hospitals and clinics. What we're seeing also is that we are overwhelming other systems just because of the numbers. We are overwhelming even restaurants for takeaway, right? Limited numbers of hours because there aren't enough people. Because I think about poop and garbage, we are actually looking at potentially a decrease in the frequency with which our garbage is picked up because the people who are hauling the garbage are out sick. So at every level of society, what we're looking at is an increase in number of people who are out. This is reflective in the CDC's most recent decision for isolation of cases, right? For the numbers of days that you need to stay home. That number was decreased in part because of observations about clinical presentation of people with COVID, with Omicron, and also some testing. But the reality is that people cannot afford to stay home for 10 days. And if they don't need to, then they shouldn't have to. And so the guidance, right, is now that if you are symptomatic, right, you will be at home for 5 days after your symptoms dissipate, and then you will be masked in public for at least that period of time. The feds, the CDC, is silent on testing. What is recommended in Massachusetts is that there is a test that people take after their symptoms have dissipated to be able to move out and about after they have COVID.
There
see
are
this
some
guy
questions.
upstairs.
There's some questions about the vaccine. One is any sense of a vaccine for kids under 5. And the second one is for those people who have been boosted, any sense of how long the booster will last? Israel's now giving a 4th shot. Is there a sense of when we will need a second booster? Will the first booster wear out after 6 months? So any responses to that? Mark, do you want to take that?
Well, I don't think we know right now, but I would predict we'll need another booster, and I'm hoping that it's multivalent at that point where we're immunized. I mean, all the boosters and all the vaccinations right now are against the original Wuhan strain, and I think it would be a benefit if they contained other variants such as Delta and Omicron as well.
And any sense on the vaccine for kids under 5?
Well, Pfizer was on a path to sort of getting approval, and then I guess they didn't show positive efficacy after 2 doses, so they're still investigating. Moderna is still running clinical trials. I know that my daughter tried to get the 2 grandchildren into the clinical trials, and they're booked. So
Well, that's a good sign, I guess.
people are not hesitating to protect their children.
And one question has come in: if one contracts COVID and recovers, what are one's options for subsequent testing to prove that one has not been reinfected?
You can be reinfected, so that I'm not sure that question
That's not a valid question. Get that man off this call.
Wendy, go find him. Is he right next to you? Yeah.
Other questions? I'm going to take a quick.
I had a question, Marcy, and it's kind of going along to what Jonathan's question was. I do know that sometimes when you have Omicron or Delta, there's a certain period of time that you can still show up as being infected, even though it's 14 days past. And so I've heard from doctors, and I'd love to hear from everyone on the call, that you can get like a doctor's note saying, I had Omicron or Delta on such and such a date, and please, note that, and because my test may still come back positive. Just curious what people think about that.
Well, the RT-PCR tests are so sensitive that they can keep turning up positive even though you're no longer infectious, and you're asymptomatic at that point. I would think that a decent antigen test at that point, if you were positive and then it shows negative, that should be good enough.
I think that's what Jonathan meant, right, John? He says yes.
Okay. Just to clarify, so it makes sense, the way the PCR test is working, it can take little fragments of the viral information that it's picking up on. So it doesn't mean that it's a functional infectious part of the virus. So that's why you can still be testing positive on the PCR, because it's finding little fragments, but they're not necessarily functional, meaning you're not infectious.
Right.
So if that makes sense for people
Right.
to understand how that happens, that's why.
So Fred Rosenbaum has asked a good question. He's asked it twice because I didn't ask you the first time, so I promise I'll ask it the second time, which is it understood why the 1918 influenza epidemic burned itself out? And can we learn I think the implication is, can we learn anything from that makes us feel hopeful for COVID?
Wendy, do you want to go or shall I?
You should go, Leah.
Essentially, it burned itself out by affecting enough people and killing large numbers of people till there was, a degree of herd immunity. But there were sporadic. So the main bulk of it was about 4 years long, but there were sporadic outbreaks in local areas for quite a while afterwards as well. Unfortunately, I think the biggest lesson we learned from it is the more people that get vaccinated, the faster we could be done, so to speak, or at least move on to a level where we're not constantly being so affected by it.
There's a question about herd immunity, and it would be nice to think that we could reach that just via having people infected, but we don't know how long it lasts. It seems like vaccination and prior infections, your protection wanes after several months.
Well, every Haftarah portion ends on a positive note, so I'm wondering if there's a way that we can end. I know that we are way past our time, and I do appreciate people staying. I'm assuming you're voting with your feet and staying because this information is very compelling, and I appreciate our speakers and our responders. Are there other questions that people have that they want to make sure that they get to ask before we sign off? I'll check the chat. Okay, any last words from our speakers? Oh, wait. Good job, Chaverim. Thank you.
If you want a positive note, I would just say the fact that we had vaccines developed so quickly, and the new mRNA vaccines, something that's fabulous about them is we can, in fact, so Mark was saying he would hope they would be multivalent, meaning they cover more strains within one shot. With the new method of vaccine, the mRNA, that is actually very easy to do, and they're already working on it. So they can change a little bit what's in it within a few weeks to a month or two, whereas the older types of vaccines would take months and months at best if you're rushing it, closer to half a year to a year. So I think something that we have to think about that's really positive is we actually have a lot of great ways to respond to this. And there are a lot of things that we can do about it and that will help end it sooner than if we didn't have any of those.
Right. And then someone just asked about the regulatory process. I believe, it should eventually become like the flu does, where it's much shorter and you only need to show efficacy,
Right.
in terms of antibody production and not have to show all the safety data again.
Correct.
And so newer vaccines should be shorter in terms of their route to market. And the other positive note is not only the vaccine end, but all the science. It's the amount of online preprints that come out every day is just amazing. Omicron's only out 5 weeks and they already have mechanistic data on it, on how it's infecting and how it's working and syncytial formation. It's hard keeping up with it.
I actually want to, I want to be positive as well, because I'm usually not. I think one positive thing is that people now know what public health is. And we never had little children or even high school or college students say, I want to go into public health, right? And so I actually want to leave you with the fact that public health needs investment, right? We have seen an absolute poop show with response to this pandemic. And people have said to me, who knew this was going to happen? Well, people in public health have been planning for a pandemic for years. And unfortunately, it's too easy to get rid of budgets when you can't see why those budgets are there and what monies are being used for. We know we can buy another bomber, right, for the military. And Jonathan, I love him dearly. We're always talking about, just give me a little, put a little bit of a half a bomber into public health, and maybe we can actually address some real serious health issues in this country. So people now know what public health is. Please vote.
Thank you. And Mark and I both put a link to the video in the chat.
Oh, show it, Marcy. Let's show it.
I just posted it.
All right. For those of you who want to stick around and want to laugh at the end of this, but first I just want to say thank you very much to Mark and Wendy and Leah and Dave, and also to Efrat for putting this together, and to Ravital, who walked me through my hosting duties on Friday so that I would not mess this up. And I'm going to end by sharing my screen and showing you the video. If you want to leave any final words before we show the video, it's really good.
So post prove to the people who still don't believe that masks are effective and vaccines are safe. How many millions of vaccine, people vaccinated and data do we need to prove that they're effective and safe? I know I saw a study with 8.5 million children. Okay, if that's not enough for you, I don't know, is 50 million enough? At which point, how much data do you need to see? It's not experimental anymore.
Okay, thank you, Mark. And now I'm going to share my screen.
Except for the coronavirus stakes, we're still
Mercy.
that social distance being loaded. Thank God there's still racing goes in.
Nope, that's the
Stock
wrong
up
one.
on toilet paper. He's quite keen to get into the barriers. What?
Sorry, I'll find it. All right, Mark, you want to put it on?
Hang on, let me find it. Okay, wait.
Marcy, you have to stop sharing your screen.
Oh, thank you.
Yeah, I can share. I have it up.
Okay.
Share screen. I think, and I have to share the sound as well. Ready?
They're off in the Christmas COVID handicap hurdle. And first to show is Omicron Lad. Omicron Lad being closely followed by the booster. Omicron Lad in a bit of an early race here with each other, the booster and Omicron Lad. Antigen Test trying to get in there. Antigen Test, Omicron Lad, the booster. Track and Trace trying to get a look in, but he looks to be struggling early doors, I'm afraid. Track and Trace. Antigen Test on the outside. Here comes HEPA filters. HEPA filters being followed by the booster. Omicron Lad, the booster. Omicron Lad not giving an inch to the booster. HEPA filters. Here comes New Year's Eve, absolutely cruising on the outside. Everybody talking about this one, New Year's Eve, looking confident and assured. The booster, Omicron Lad, HEPA filters, Track and Trace is knackered, he's gone. New Year's Eve is coming fast. Sudden spike appears out of nowhere. Sudden spike, the big danger. New Year's Eve, the booster plugging away gamely with Omicron Lad. New Year's Eve, sudden spike. Here comes Leave Them Kids Alone. Leave Them Kids Alone. Sudden spike, New Year's Eve, and a late challenge from It's Only a Cold. It's Only a Cold. Sudden spike, Leave Them Kids Alone. The booster, fourth dose. Nobody saw this one coming. Fourth dose out of nowhere. It's only a cold. Fourth dose. It's only a cold. Leave them kids alone. Fourth dose. It's only a cold. Oh, I have no idea how they're going to sort this one out, to be honest with you. They all crossed the line together. New Year's Eve just crossing the line now, absolutely spent. And Track and Trace is still running, would you believe? Happy Christmas.
Thank you, Mark. And on that note, we will say Lila Tov.
Lila Tov.
Stay safe, everybody.
Bye-bye.
Thank you so much.
Thank you and bye-bye.
Bye.